So community dwelling older adults. The key here that I wanted to focus in on, or just kind of set the stage, is that they're all different. There's a continuum of older adults. I mean, who's old? I don't know. Nobody, everybody. But for this presentations, we're going to be looking at older adults, 65 and older. But there are folks who are younger than that who experience a lot of frailty issues. And then there are 90-year-olds who have very little in the way of expressing or showing any kind of frailty. So there's truly a continuum. And depending on how mobile you are and able to live in the community, we're specifically looking at community dwelling older adults for this presentation, because then you have those who are in assisted living, and then you have those who are in skilled nursing homes. You have quite a range, but we're specifically focusing in on oral health, frailty, and community dwelling older adults, and then decreasing the risk of moving into a higher level of frailty, and the importance of functional dentition. So a lot of terms there. I will just say up front, I'm not a specialist in geriatrics, but I have, as we all do, learn and dig into the literature and gain more appreciation as we work with the topic and work with people as we're moved in that direction. So I certainly don't have all the answers to this. I would imagine a number of folks on this call have much more background in geriatrics than I do. So I appreciate any discussion or comments that you might have. I have no conflicts of interest. Of course, my background's in higher education and curriculum for practicing clinicians and faculty. So I got to start with learning objectives, don't I? So the main thing here is that we're just going to go through some different concepts, some basic understanding, kind of foundational and higher level information. But the main thing I want you to get out of this slide is that ACOA stands for Oral Care for Older Adults. Because once I start throwing out acronyms, I don't want anybody to scratch their head and say, ACOA?
Changeable with very old age, multimorbidity.
How's that?
Okay.
Perfect. Thank you.
Disability, particularly ADL dependency. And it was getting the field into trouble to have no specificity about what we were talking about beyond I know it when I see it as a clinician. We moved in the 1990s to the challenge of trying to figure out whether in fact that was true, that all those concepts were interchangeable. Or aging, multimorbidity, specific diseases, and frailty, the same conglomeration of stuff that were indistinguishable. And it was a challenge I particularly saw in caring for older patients, that frail patients, I knew it when I saw it because my frail patients looked different. They looked different. And that began my own personal journey, but many other people as well, trying to wrestle with what we were talking about. And I think in the 2000s, we emerged into some shared discussions about frailty being a distinct geriatric syndrome, not the same as multimorbidity and disability, and perhaps with a distinct pathophysiology. To mark your 10-year history, I'll create a somewhat arbitrary dividing point here and say that since 2009, although it somewhat matches our own research, we have really been trying to characterize what I have come to believe is a distinct medical syndrome, like angina, and that this frailty syndrome is linked to a distinct underlying pathobiology that is aging-related, but perhaps accelerated by disease. And increasingly, I believe, I'm trying to tell you the punchlines first. increasingly, I believe, is the inverse of resilience. Accumulated damage along the way, as clinicians, we know that that matters, that the more disease burden you have, the worse shape you're in, just to be a little glib about it. So it wouldn't come as a surprise to think that accumulated organ system damage might have some effects here. Might. And now, since 2015, the National Institute on Aging has been leading really the development of the new geroscience, which has an organizing thesis that there are shared biologic pathways that emerge that are aging related, aging associated, aging driven, and that may emerge in the presentation of a syndrome of frailty, as well as emerging in terms of disease development. So this is the arc that I'd like to present you with right now of where we've ended up, at least as I see the field. I started thinking about this as a young geriatrician for reasons that were various. One is I didn't know what I was talking about when I knew it when I saw it. And it was very clear in the literature that what I knew, what I thought I knew, didn't always match what everybody else thought they knew. And we couldn't even actually characterize our patients unless we could develop some specificity. And I did about 10 years of research that you will never hear of because nobody would ever publish the papers, trying to figure this out. And it was very clear that this is a simple list from a series of studies I did asking geriatricians, what are the markers that you recognize that makes you think someone's frail? What are the clinical stigmata? And there was this list: declines in lean body mass and strength, weight loss, loss of endurance, slowed walking performance, relative inactivity, maybe even homebound, and sometimes and often decreased balance and mobility. I spent 8 years doing studies trying to figure out why these things were in the same list. And came to a conclusion, painfully, I would say, that in fact it was obvious. That in fact, if you think about it, we know there are pairwise associations between everything on that list. So let me try and take you through that. And since my pointer doesn't work on both screens, I will try and talk you through this if you start on the right-hand side. So everyone agreed that sarcopenia, the loss of muscle mass with aging, was somehow an anchor point in the development of frailty, whatever it was. And we knew at that point that sarcopenia, if you go straight down, predicts declines in strength and power. It predicts decreased exercise tolerance, and it also affects resting metabolic rate. And we knew that declines in strength and power and declines in exercise tolerance, because of science being done then, both predict declines in walking speed. And we knew that declines in walking speed actually predicted cutting back on physical activity. And we knew at that point, through really groundbreaking science that was coming out of Tufts, that there was a subset of older adults who had low physical activity on the left-hand side, and yet were taking, even at those low levels of physical activity, were somehow not regulating their dietary intake, so that even when they're expending almost no energy, they were taking in even less dietarily. So they were not matching one to the other, and were chronically undernourished. And we know that chronic undernutrition on the top of this figure worsens sarcopenia, and when it gets really bad, you get into a negative energy balance, and you start losing weight. So we knew about this pairwise relationships, and if you put it together, it becomes, at least to me, very clear that what I see here in terms of a cycle of frailty, which I proposed in the late 90s, actually matches the clinical presentation vicious cycle that I saw in my patients. Now, I'll make 4 points about this cycle. Number one, as with many cycles, you can kick it off at any point in the cycle. And perhaps there are specific diseases which kick it off at different points in the cycle. Number two, the cycle, the whole is greater than the sum of the parts here. Any one of these may matter, but it's when the weight gets too great of the whole cycle that you start to get a sense that someone's frail. And number three, if you look at this, what you see going on when you link all these things together is the suggestion of a cycle of dysregulated energetics.
A video is worth 1,000 words, right? So I thought I'd bring in a specialist from NYU from Columbia University to share kind of a basic overview of frailty and just the background of it. So the field of frailty has evolved over time. It's not that everybody who's older is frail. And of course, there's different levels and there's a continuum. But the idea that it's all connected, that it is a part of the aging process, but it's much more the degree. So individual factors for the aging process is chronic and acute disease. And I was really glad with this particular graphic that they did include oral health. There are sensory changes, strength and endurance, balance, cognition, nutrition, and health beliefs. And then there's external and environmental factors, which we encounter a great deal at the St. Louis Dental Center in the heart of St. Louis, of housing and social network issues, difficult living environments, maybe a lack of social support, certainly nutritious food availability is a challenge, and then health resources and access to care. So we work to overcome and address social determinants of health on definitely a daily basis. So specifically for oral health in older adults, those who don't have good access to care or maybe feel like I'm older, so I guess I'm going to lose all my teeth. There's a problem of untreated tooth decay, gum disease or periodontitis, resulting in tooth loss. There could be an issue with smoking and concurrent alcohol use leading to oral cancer, and then an aggravation of multitude of chronic diseases. So teeth that are not cared for at home and during regular dental visits are at risk for any number of these issues occurring. And not to beat a dead horse, but it's important to remember that the head's connected to the body and there is a systemic and oral health link. So just thinking in terms of your gums, you brush your teeth this morning, you get all that plaque off, hopefully you didn't see any bleeding. But older adults may not even know that they need to brush their gums to have their tissue healthy, to have healthy teeth, to really get all that plaque off, may not really know how to do that. And again, like they may think they're going to lose their teeth anyway, so why bother? But every time that your gums, if you find that when you floss or brush, your gums bleed, that's a sign potentially of a breakdown in the skin or the epithelium, which allows bacteria to enter the epithelium and then into the connective tissue, then into the bloodstream, which then stimulates and causes pro-inflammatory mediators, which then cause all kinds of problems. So the graphic on the right just gives you a sense of the number of issues that can be contributing, that oral health bacteria into the bloodstream can contribute to systemic health. So it's not really an oral health issue. It's not really an older adult issue. It's not really a specific chronic disease issue. when we talk about oral health and frailty and helping older adults be active and involved in the communities, to stay in the community as a community dweller, we need to think in terms of a much, much bigger picture. And that's why I was excited at the idea of being able to share this information with all of you, because a lot of you come from different backgrounds, different perspectives, different lenses. And in dentistry, we're always wanting to say, yeah, there's dentistry and we're focused in on that mouth. But we are always aware that the diabetes is aggravated by untreated periodontitis. We're aware that the bacterial infiltration into the bloodstream can aggravate heart disease and stroke. We know that it just, bacteria in the wrong place just causes the body to go crazy. Very, very technical. But the idea, we want to kind of connect all of us on this call, and maybe those viewing it later, that what's going on in the dental schools and what's going on in the PA program, physical therapy, medical, it's all connected. Pharmacy, really, truly, that we would get to the point of seeing all of us as a larger unit, much like body systems, and then figure out how we can connect what we do and how we do it to screen for each other's issues and do referrals, which I'll talk more about later. As far as oral health, this is an interesting picture in that in the upper left-hand corner, we see a gentleman flossing his teeth, but he may have arthritis. He might have a really hard time getting that floss wrapped around his fingers to get in between his teeth. And then the picture on the left with just the teeth, and then the lady on the upper right-hand corner, you can see that you have teeth, but they're not there are no teeth opposing them. So you could imagine that those front teeth can bite something off or rip it off, but then when it goes to the back teeth to grind and chew and make it into small pieces, able to get more nutrients out of it, start the digestive juices flowing, and get it in smaller particles, there's nothing opposing it. So when you chew down on something and there's just tissue and bone there, you really get very, very poor nutritional value out of the food you're eating. And so what we want to do, and what we do at our dental school, is to assess the places where teeth are missing and then create prosthodontic appliances such as a partial or even dentures. And it was such a hoopla to get to that other video. I may just have you get to that later. It just talks about health disparities and how hard it is on people, the emotional trauma that individuals go through when they smile and there's holes in their teeth, and they talk a little funny because they don't want people to see. They bite down on things and it hurts. They try to chew, but their dentures don't fit, and so they fall out and they just don't wear them anymore. Then they don't want to go out because they have no teeth. There's just a lot of different components that go into mental, emotional, and physical health if your teeth are hurting you, or you're missing them, and you think that you just have nowhere to go because you can't afford it. So oral pain is definitely affects anybody's quality of life, but certainly older adults. It's a sign of advanced problem of the disease of the teeth breaking down, cavity or gingiva or the gum tissue being abscessed, or having infection in it. If there's an abscess, definitely difficulty eating. Just close your eyes and think about, you have a few teeth on the side and a couple teeth in the front, and someone gives you an apple, or they give you an apple slice, or they give you a corn on the cob. anything like that, you're not gonna eat it. So what are you gonna eat with if you're missing teeth? Maybe mashed potatoes, maybe Ensure, maybe, whatever you can get down, given you don't have teeth or your teeth hurt, you're going to make adaptations. And oftentimes the adaptations are eating poorly. And that just continues on and on and on. And if we think about that graphic that was presented earlier, where everything fits together. And if you have poor nutrition, that sets up the rest of your body to not have the nutrients it needs to function in a healthy way, and certainly not to sustain any kind of assault that may come from a disease or external stressors. So again, it's all very connected and very circular. And of course, the issues with medications and multiple medications often causes dry mouth. And dry mouth doesn't allow the saliva to clear out the food well. And if the food isn't cleared out well, then you most likely will get more cavities, because there's not that buffering effect and there's not the clearing out effect. And it's hard to swallow. Very hard to swallow. If you think of taking in a bunch of crackers and you're chewing on it and you just don't have enough saliva, it just sits there. So there are many reasons why the oral health affects the quality of life, and nutrition is one of the main ones. So we did get a very good definition of frailty and some background on the issue, but it's a vulnerable state to stressors resulted from age-related declines in function and reserve across multiple physiological systems. So it's like a cycle. And it's considered to be malnutrition resulting in a cycle of malnutrition, appetite loss, muscle loss, and weakness, fatigue, and decreased energy. So there's more and more research coming out that connects oral health, lack of teeth, dental pain, the number of teeth that are actually occluding and oppose each other that you could grind and chew, to the not being able to eat quality, healthful food, and then moving towards a poor quality of health or frailty. So in one cross-sectional study, an association was found between frailty and self-report oral health in community-dwelling older adults. In another study, older men who lost weight from baseline, had lower BMI, had higher prevalence of frailty and depression. They reported poorer appetite and had fewer teeth than those who did not lose weight. Isn't that the only factor? No, but it's a contributing factor. And then finally, in a systemic review of nutritional status of oral health in elderly, well-nourished subjects had a significantly higher number of pairs of teeth, functional teeth, in comparison to individuals with risk of malnutrition. And there are lots and lots and lots of more studies. If you're interested, I can share with you more of the literature that's out there, but this is a kind of a good representation of the type of literature that's coming out and saying oral health makes a difference. And we want to start looking at it and thinking of it in terms of bringing someone from an early state of frailty to a healthy state by addressing not only their physical therapy appointment or nutritional counseling, but also to make sure that they are referred to an oral health provider for a oral health assessment as a part of their treatment planning. So that brings me to oral care for older adults, our COA project. In September 2000, well, actually summer 2020, Missouri School of Dentistry and Oral Health received almost $1 million grant over 3 years to provide dental care to City of St. Louis residents who are 60 and over with 200% or below income level. They're living independently, and so we received these grant monies. We hired a project manager We started reaching out to Affinia Healthcare, which the community health center that we're embedded in, and then area agencies, going to living centers, or the intent was to go to independent living centers and do education programs. But of course, guess what? That was right at the start of COVID. So we did what we could. We kept the classes small. And even so, this grant started right at the front end, more or less, of COVID. Yet we still have been able to reach out to many, many adults in our education class. And we have so far 224 older adults have received dental care at no cost. Now, of course, we tap into any kind of insurance that they have in one thing or another, but our aim is to provide functional oral health, not a beautiful set of teeth with all caps and, great aesthetics, although many do get that. But our purpose is functional dentition, so that they can chew, they can enjoy their food, they can smile and feel good about themselves, and then actually be able to enjoy healthy food, and not just soft foods that may or may not provide much nutrition. The money for this project is part of a voted on initiative, a tax levy that the citizens voted for several years ago that provided money for older adults in St. Louis. And so it's a tax-funded project that we applied for part of the funding, and we've received that 3-year grant. And we hope and are looking forward to receive continued funding, so we can continue to reach out to the many more thousands of older adults in St. Louis that desperately need help. And just to kind of give you an idea of St. Louis, these are it's just a snapshot of the type of folks that we see at the St. Louis Dental Center, which, for those who may not know, our dental students start their first 2 years of school, D1, D2, first year, second year, in Kirksville, getting the basics, foundational biomedical information. Then they literally move down to St. Louis in their third and fourth year, and provide care at the St. Louis Dental Center. So the St. Louis Dental Center actually is embedded within the Affinia Healthcare, which is an FQHC. And our students, supervised by our full-time faculty and specialists, provide the actual dental care for patients. And Affinia Healthcare actually owns the patients, and their support staff manages the insurance and other things like that. So it's a very unique partnership. And of course, it has many, many advantages. And one main advantage is that we can provide high quality, low cost or no cost care for those who are the most, who have the least amount of opportunity to get that kind of care. As you can see, 35% have no insurance. And one thing to remember about older adults is that when you retire, your dental insurance goes away, and Medicare currently does not include dental insurance as a part of its benefits. And so we're looking and hoping to get that changed in a number of different levels all over the country. But for now, many adults don't realize that they're going to lose their dental insurance once they retire, and have limited options to get the dental care that they need. So for us to be able to be at Affinia Healthcare, working with all these really cool people who need a lot of things, we're able to provide some of that care for them, and to be able to get tax levy money to be able to do that is really quite a win-win-win on a lot of different levels. One thing that we do for all of our patients coming in, or ACOA patients coming in, or being screened, I guess, to see if they are eligible for the program, we have a Toothwise education program. Over an hour's time, our lead education lead educator, Lori Crawford, who's a dental hygienist, provides nutrition information, home care information. And one thing Lori often says is that a lot of the older adults are just really surprised. They really thought that they were going to have to lose their teeth. There was no help for them. They're just going to have to deal with it. And she gives, through these education programs, she gives some great information, how to stay healthy, how to help their mouth stay healthy. We worked with Dr. Weisnat from the ATSU School of Osteopathic Medicine in Arizona to create a little bit more robust section on nutrition and general health, which was a great addition to the overall program that Lori had put together. And so all of this older adults who are part of our program get this great education program, and they receive a oral cancer screening. Our dental students come in and help with this. And it's at this point in time when they come in initially for that screening and assessment, if they are able to be in our program and receive this education program. That is at the point in time when we administer our quality of life surveys and some other assessment tools, which I'll talk and describe a little bit more. But it's at this point in time, that initial appointment, that we start collecting our prospective data to capture the self-report quality of life indicators of these individuals who are able to come into the ACOA program. When we wrote the grant, I went ahead and selected the REAIM model to assess all the different levels of formative and summative assessments, both interviews, internal and external advisory boards, self-report surveys, and then we have extensive data in our EDR and EHR that we can look at. Given the intent, this is not intended to be a research project. I'll just say that up front. The intent is to provide care for the underserved as defined by the grant. But of course, we don't want to miss the opportunity to collect the data that is a part of what we're already doing almost anyway. So for the surveys, we go ahead and collect demographics. Then we use the SF8 quality of life survey. And then we also administer the GOHAI oral health quality of life survey. With those two indicators, we do that at the initial education program, and then at the end of treatment, and then the follow-up recare appointments 6 months out, 1 year out. And we hope to follow this cohort in this prospective study for as many years as we're able to have the grant. The initial indication of this data is very positive from the time when they come in to the time that they have completed their treatment. And we expect a continued improvement as they are able to continue to eat better food and gain strong, and for all the different things that will accomplish to hopefully keep them from going into a frailty state. We've also added a sleep apnea screening question to see if this is an issue for this population. And then another research project is to assess the number of teeth at the comprehensive exam and then at completion of treatment, and then compare that data to the quality of life surveys. So I'll just say here that we have an enormous amount of opportunity that anybody's, who's ever on this is hearing this. We welcome any interest in this data set and what we're doing as far as a collaborative research project. If you're involved in any kind of geriatrics assessment, there's a lot of potential. We will not burden our patients with a lot of extra assessments because it's not a research project, but there's a lot of data already being collected that we don't have to do more. We just, have opportunity to use that to assess what this intervention can be doing. Of course, you know, and I know there's a lot of variables we can't possibly control for. But yet, there are some great data using these surveys. They're validated, and you put it all together, and you have some great outcomes starting to present themselves. And then our dissemination activities, you could read those. We needed to wait to get some of the data for pre-post, but we're very excited at the idea of starting to share what we're doing and get this out there as a demonstration project, with the idea of a dental school embedded in a community health center as that safety net, and how we can really start changing the health system to partner and connect in different ways, not just interprofessional collaboration, but truly in a business and scheduling and fee sense. What does that look like to really, really help different groups of people and to address the social determinants of health that we see all the time, every day? So I'll just say again, for interpersonal opportunities, looking at this graph we saw before, we have so many different healthcare programs in ATSU, and the idea of maybe coming together with one specific issue in mind and coming at it from multiple perspectives, and possibly utilizing the data we've already collected to look at different things. It's kind of, to me, it's exciting. So as far as interprofessional care and healthy aging, I think we all would like to think in terms of screening patients who are 65, 60 and over for all the different components that contribute to the development of frailty. It'd be medical and dental and nutrition, substance abuse, emotional health. We want to screen for all these different things and more of a holistic approach, even if they're coming to us for issues related to arthritis. That all contributes to an adult that may, they're losing their capacity to be agile and resilient. And it really is in their interest, and certainly in our ability to have a broader perspective of whatever entry point into the healthcare system, to think of the overall. And also the importance of warm handoff referrals. It's very easy for older adults to get lost in the shuffle. They may not be able to get a ride. They may not understand what they're being asked to do. There's so many things that, it makes it difficult. One of the key points of success for our ACOA project is our program manager. She has an MPH, and she has dedicated herself to create databases, follow-up, insurance protocol, any number of things that actually address many of the issues that older adults face and that try and help them overcome. And then to address the barriers to accessing all types of healthcare. So we work carefully at looking at their insurance, looking at lack of transportation, health, one thing or another, and then networking with local agencies with what they're already providing to see if we can tap into that. And then in a recent report, which I highly recommend if you're wanting to dig in more into this, is Older Adults: Unique Challenges at the Interface Between Nutrition and Oral Health. It's an excellent report. It has a great deal of information that would take this brief overview and just provide a lot more resources and information for you. So I just would like to thank my ACOA team, our ACOA team. Patty Inks is on this call, and then our program manager, Jane Clark, and our outreach educational specialist, Lori Crawford. So with that, I'm going to stop share and leave time for questions and discussion.
I can just kick in a minute here since nobody's speaking up. This is Patty. So we had a little pilot with some people that we used just the GOH AI survey for that we've completed now as part of one of our D3 research projects. And we're getting very positive feedback about the improved perceived quality of life. So it's going to be really exciting as we move forward with more patients and with the additional medical, survey questions for the OCOA patients to see if those results continue to be positive like that. So far the patients have been really thrilled to be part of it for the most part.
Thanks so much, Patty. Any other thoughts or comments or questions?
I have one. The grid that you presented and like the outreach and interprofessional, like how you actually line up services for your patients. I'm just like wondering if the CHC has, wants to take it over, like wants to adopt it as their way of serving patients.
Well, so we have a legal agreement, truly a legal agreement, financial agreement, practice agreement with Affinia Healthcare, which is, I think, somewhat unique in the nation. And so if we've adopted it, so have they. In the sense that our patients are not our patients, they're their patients. Their staff is their staff. And their accreditation and their JCO and everything else, it's tied into what we're doing as a dental school. And so whether they do that in their other facilities or not, they didn't really get the grant the dental school did. So at the dental school, Deb, it's just so hard to separate out. It's really, really intertwined as a business partnership. But we're hoping that in some of the articles that we'll be publishing to share it as a unique model for a business, a unique healthcare model of private and public and city funds to address a huge healthcare issue that has been very difficult for many people. Because for the most part, oral healthcare for adults who have no money to pay for it just don't get it, or they have to go to a special day where a lot of dental care is done, and then there's nothing else for another year. It's more of a missions outreach, but there aren't a lot of options out there. And this is a tangible, functional option.
And it's interesting because it's tax funded, they have to be city residents. So that narrows the scope, and I think it's cleaner for the grant agency that we have the money and then we pay Affinia. So it's not that they granted us the money and us telling them how we're spending it. So it's almost cleaner for the granting agencies to have that in between, that they're giving the money to us and then we release the funds to Affinia as the services are rendered. And also here, we are fortunate enough working with Affinia that they give us the sliding scale cash fee price for things, like when we're doing the dentures and stuff, so that, it's a unique situation in a community health center too. The billing is totally different than what people deal with in private practices. And so we're fortunate to be able to use our reduced fees for when we're charging the people for this grant.
Debbie, did you have a question? I saw that your mic was unmuted.
Yeah, I was just going to mention, I know you're way into this, but I didn't know, because I know, was it last year that you and Patty did a lecture for the Summer Institute at St. Louis University?
Yes.
Yeah, and so frailty, I'm part of the geriatric workforce enhancement program. And so we look at frailty, sarcopenia, that older age, malnutrition, and then the cognitive impairment using the rapid geriatric assessment.
Yes.
And I didn't know if that was a tool that maybe Affinia would be interested in, looking at, and maybe you've already talked about that.
It's a good point. I certainly can bring that up. We have an internal advisory board and an external advisory board. It's a good point, Debbie, in that it's such a there's so much potential.
Right.
So to add that in is a possibility, but again, because of older adults' time span, we need to get that assessment in, we need to get the education in, the oral screening, and then get them, the ride home.
Right.
We're not saying it can't happen.
Right.
But I think you're right. That's throughout all the literature. And I probably need to bring it up as a validated assessment tool. But for now, we just went with the self-descript quality of life surveys.
Right. And I think honestly with the RGA, the frail and the sarcopenia and the nutrition, those could actually be done, the patient could self-report on those. And then if you wanted to do the cognition screen, you could, you wouldn't have to. But right. Anyway, I just thought I would mention it because I was like, oh, this is just so in line and in tune with literally everything I do every day. So
well, sign you up. Because there's so much potential for research, I'm always having to have my hands slapped to back up because it's not a research project. And so the capacity for what we're able to do is relatively narrow, unless we had someone come in as a research assistant and worked with me and leverage what we have, which I welcome. But I know you can hear what I'm saying. It's a direct care grant, and the evaluation part I salivate over, but I really have to be mindful. We have so much time.
Right. And I don't do research with the RGA. I know they do it. They have it SLU. I don't particularly, but anyway, it's just, I thought it was a valid, tool to at least kind of mention and
it is.
Thought
Thank
maybe
you so much.
Probably had some experience with it.
Yeah, absolutely. But thank you. It's a great point.
Yeah.
Anybody else? Are there any questions in chat, Deb? I'm not looking at it.
No, I have one comment from Patty, and it says health literacy of our patients is very limited. Self-reporting is limited.
Yeah, about third grade.
Yeah.
Yeah. So, and I will give a shout out to Mary. She's working with us on our stats for the project. Thank you, Mary. So are we good?
I guess we are. I mean, I believe people are digesting it. I would, if possible, Dr. Davis, I will reach out to you later, see about, I mean, this looks like an extremely adaptable model, and it could be, different cities. I mean, wherever the CHCs are located, they can follow this and see if this can be implemented. And it's just amazing, sustainable model to follow. It's
yeah, we have to think differently. The idea of integrating community health centers, FQHCs, with existing dental schools, dental hygiene schools, nursing schools, and then the tax levy from St. Louis, it is just a fraction of a penny of the overall tax bill that someone would get, and we just get a small part of that bit of tax levy. And it was the citizens who voted for it, but we feel very responsible to the Board of Aldermen and different ones to be accountable. We give regular reports. They're very happy. We think it's positive that we might get continued funding because we have followed through and made our deliverables and have these evaluation loops. So it is sustainable, which is a problem with a lot of grant projects, is that they're not. The money drives up and the great program goes away. So, well, great. Thanks, everybody. And I'm going to stop recording now.